Hello, everyone, and welcome. My name is Emily Noodleman, and I'm the Director of Implementation and Outreach at the Foundation for Healthcare Quality. In my role, I primarily support our BRIE collaborative program, and we're so happy to have you with us today for our Catalyst for Change, Energizing Innovation for a Resilient Behavioral Health System. This webinar is the first of a three-part series that we're co-hosting as part of the foundation, also with Comagine Health and Washington Health Alliance. We're trying to spotlight innovative work shaping the future of healthcare in Washington State on key topics such as chronic health and rural health as well. We recognize it's been a challenging time within our healthcare system, and so we want to talk about resiliency and innovative opportunities to continue this great work as we face budget cuts, staffing, and many other challenges. We recognize the healthcare landscape, again, is continuing to shift also with the policies and system demands. Organizations across the state are really adapting with resilience, creativity, and collaboration. In today's event, we'll focus on behavioral health, and our panel of leaders from across the healthcare continuum, including hospitals, clinics, health plans, and community partners, will share the approaches that they're taking to strengthen behavioral health in Washington. We hope that you'll gain insights into emerging strategies, real-world challenges, and opportunities to drive meaningful improvement across the systems. Before we jump in, I just want to review some items with you. Upon joining and entering the webinar, you have been placed on mute. Throughout the presentation and the panel conversation, you are welcome to ask questions to our speakers. Please write questions you may have for our presenters in the Q&A box at the bottom of your screen. We will be reviewing those questions and asking them on your behalf. The webinar today is being recorded, and we plan to send out a slide deck and the recording to you via email, and it'll be posted on our website. We'll start off today with just the introduction and hellos from the different groups co-hosting this event, and then we'll jump into our panel and we'll get some Q&A with our speakers and wrap up. So I'm going to invite some introductions, first from Ginny Weir to talk about from the Foundation for Healthcare Quality.
Hi, everyone. Emily and I are in the same room today, so we're going to coordinate this way. And thank you, Emily, so much for leading this. I love these collaborative webinars with the Washington Health Alliance and Comagine Health. I think they're just a great space to highlight what's working in our state and really energize people around things that we're all very passionate about. So the Foundation for Healthcare Quality is a neutral nonprofit, and our mission really is to catalyze quality improvement through collaboration, through insight from others, and through evidence-based practice. Behavioral health is a huge part of many of our areas of work, but I wanted to focus on our BRIE collaborative guidelines, just highlight those and elevate those today. We have quite a number of behavioral health oriented guidelines. It's been kind of a through line throughout our work. 2024, we developed behavioral health for youth guidelines, as well as opioid use disorder treatment. 2025, first episode psychosis guidelines. And in 2026, we have the opportunity to develop guidelines around menopause, which I'm very excited about. I know there are a lot in our community who really are, and kind of the way that behavioral health comes up for people as they go through that period of life is a space we're really excited to dive into and develop guidelines around. And I am going to turn our virtual stage over to Denise Giambalvo.
Thank you, Ginny. I love being here with you and Michael and the collaboration that we get to do together, and particularly this year getting to bring mental health front and forward. Such an important topic. And at the Washington Health Alliance, our mission is to act as a collaborative force to drive healthcare system change to improve quality, access, and affordability. And an example of how we're doing that within mental health is we have a grassroots multi-sector work group that has come together to solve how we receive and report on behavioral health outcomes data with the primary aim to shorten the time to patients' improvement in function and quality life and benchmark quality access providers. And so if you're a member and not involved and you'd like to be, reach out. And if you'd like to learn more about it as a non-member, reach out. Thanks. Oh, and I think I'm supposed to turn it over to Michael now. Sorry, Michael.
No worries. I appreciate the opportunity to be here today, along with Jenny and Emily Noodleman and you, Denise. Representing Comagine Health today, we're just excited. Our mission is to reimagine healthcare with community and with our partners. Our goal is to improve health and create a better healthcare system so that people and the communities that they live in will flourish. And part of that is we've long championed whole person integrated care, providing technical assistance and coaching to both physical and behavioral health providers on practical approaches to improve their workflows, expand their care teams, to measure impact, essentially to better meet patient and client needs in service of improving their lives. We're excited to be collaborating with all of you as part of this Catalyst for Change webinar series and look forward to learning more about advancing behavioral healthcare in Washington State from the esteemed members of our panel. I know there's going to be some great ideas shared here today, so looking forward to it. Thanks.
Going to continue with this rolling in and out bit that apparently we started. And we're going to welcome our speakers. Oh, I thought this was updated, so I'm so sorry, Stacey. We will start with you, but we want a moment to introduce our speakers to all of you. We have the lovely Stacey Lopez with us, who is from the Sound Behavioral Health. We have Dr. Mike Franz, who is from Cambia Health Solutions. We have Esther Lucero, who's the president and CEO at Seattle Indian Health Board. We have Joan Miller, who's the Chief Executive Officer at Washington Council for Behavioral Health. And shortly, I believe we will have Emma Plazola. She is the Perinatal Safety Specialist at St. Francis Hospital, who I think got caught up in some patient care, but we recognize that comes first in all situations. We want to really welcome our speakers today and thank them for participating with us. We will start with just some brief introductions. And so we'll ask them to share their name, role, and how in their organization's role is supporting behavioral health in our state. So I'll pass it to Stacey.
Thanks, Emily. Good afternoon, everybody. My name is Stacey Lopez. I am the Chief Clinical and Quality Officer at Sound Behavioral Health. I'm sitting in for Katrina today. She was not able to join you. Sound is a large outpatient behavioral health organization in King County. We have 11 outpatient sites, 3 residential treatment facilities, 2 providing mental health treatment, and 1 which is a long-term care extended service facility. We have been around 60 years. Traditionally, we have served the Medicaid population and those with serious and persistent mental illness. And then with the expansion of Medicaid in 2018, it expanded our service population. So now we are a full range provider with all levels and cares of mental health and SUD services.
Thank you so much. I'll pass it to Joan.
Hello, everyone. I am Joan Miller, the CEO of the Washington Council for Behavioral Health. Thank you so much for inviting me to be here. The Council is the statewide association of licensed community behavioral health agencies. Our member agencies provide services primarily to Medicaid enrollees with a serious mental illness or substance use disorder. Sound is one of our members. But we have members all across the state in every county, every legislative district. And the council's mission really is related to public policy and advocacy. My work is to support our member agencies at the state and federal policy levels in order to strengthen our public behavioral health system so the people that we serve get better access to the health care they deserve.
Thank you so much. I'll pass it to Esther.
Yat everybody. My name is Esther Lucero, and I'm Diné on my mom's side and Latina on my dad's side. And I serve as the president and CEO for the Seattle Indian Health Board. Seattle Indian Health Board is an urban Indian health organization and a federally qualified health center. We operate 3 bricks and mortar sites and 1 mobile unit, with soon to come a 92-bed residential treatment facility, Thunderbird Treatment program out on Vashon Island. It will be opening on July 11th. We offer both outpatient mental health, outpatient SUD, intensive outpatient, and then soon to be residential, all centered on traditional Indian medicine. So a unique experience, a unique approach to culturally attuned care. Thanks for having me today.
Thank you. We are so excited for that. That's going to provide just such a depth of resources for this area that is deeply needed. And it's just very, very exciting that your group was able to grow that. So thank you. I'll pass it to Dr. Franz.
Hi, thanks. Yes, I'm Mike Franz. The pronunciation is like Hans and Franz from the old Saturday Night Live skits, in case you might forget. I'm the Executive Medical Director of Behavioral Health at Regis Blue Shield in Washington, and actually lead that across the enterprise in 3 other states as well. My role there is really to lead strategy to bring timely and effective as well as affordable behavioral health care to our members. And in addition, I'm still a practicing child and adolescent psychiatrist, and I consult to pediatric primary care on Friday mornings doing the collaborative care model and e-consults. And then I run a neurodevelopmental complexity clinic for kids with nonverbal autism and some genetic syndromes on Friday afternoons at our community mental health center. It's a pleasure to be with all of you today.
Thank you. And I'll pass it to Emma.
Hi, I'm Emma Plazola. I'm a perinatal safety specialist nurse, and I work at St. Francis Hospital in Federal Way, Washington. We're a community birth center, and we do about 1,500 deliveries a year. And our work intersects with behavioral health in a number of ways, but specifically, we help we screen all of our patients for perinatal mood and anxiety disorders before discharge, and we make sure that those that are screening high or are high risk get connected with both social work, a collaborative plan of care with their OB prior to discharge, and make sure they have those community resources before going home.
We recognize in today's call and in general, behavioral health can really impact anyone at any age in any capacity. And we are highlighting in today's webinar a lot of different perspectives on that age timeline. And so you are welcome to ask questions about that as we kind of highlight that this can happen to anyone, both as an individual experiencing that diagnosis and situation, but also being a family member of someone, a close friend or others that may be impacted as well, especially as Emma's pointing out, a couplet of a parent and baby. I just want to start off today just talking about what do each of you see as the most significant shifts in Washington's behavioral health landscape over the past few years, and how is your organization adapting to that or supporting work in that area? I'll start with Esther, actually, for that.
Thank you. I think that the most significant shift was actually a consequence of COVID. I think that we saw several residential treatment programs close. I think that there was a scarcity of detox centers. That has been incredibly challenging. I think that obviously the funding mechanisms have been really challenging as well. And I think that's one of the reasons that some of these facilities have closed. I think for our organization, what we have done is we've tried to fill some of those gaps. So our largest focus has been on reopening our residential treatment program and actually enhancing it to serve pregnant and parenting people. So we will have 15 beds dedicated to serving pregnant and parenting people, where they will be able to bring children up to the age of 5, 2 children with them up to the age of 5, to keep that family unit intact. I also think that there has been little investment in culturally attuned programs. And so I think that we have a lot of organizations like within our environment where there is opportunity to kind of grow capacity quickly rather than trying to duplicate capacity. That often happens within the county system. So I think it's been a very difficult time for behavioral health, the whole behavioral health continuum. And obviously the mental health needs, particularly inpatient mental health needs, are just very scarce resources. So I'm looking forward to partnering with our tribal communities to understand how to maybe reconcile that challenge as well.
Thank you. Pass it to Stacey to talk about sound behavioral health, kind of again from the provider, like the system providing.
So I think a couple really significant events were COVID, we shifted from doing, I think, 4 telehealth events in February of 2022 to like 1,500 in March of 2022. So one of the reasons that was significant is because it's a muscle we have developed and continue to use. It just makes healthcare accessible in a different way. So there remains a good portion of the people that we serve that prefer to continue to have telehealth services for behavioral health instead of coming into the clinic. So I think that's been really beneficial for the people we serve. The other thing that's been very significant in our part of the behavioral health universe is Medicaid expansion. When that happened, we all of a sudden had a whole new patient population that was able to access care. And these were mostly folks that had not had any sort of coverage before. And so it gave them an entirely new avenue to pursue health. And so I think those have been really significant for us. And the last thing I think is the evolution of the crisis system. It's really developed over the last few years. And we at Sound have stood up 2 of the mobile rapid response crisis teams. So 24/7 in most areas of the state, particularly in King County, you can call the crisis line and a trained mental health professional and a peer will come out and respond to you in the community and help get you through whatever's going on and link you to the next most appropriate resource. So I think that evolution of bringing services to people in need in a way that they get to remain in control in a least restrictive setting that isn't focused on law enforcement or hospitals has been a game changer for many people.
Thank you. I'm going to come back to the concept of or ask you to elaborate in a little bit on that peer piece too, because I think that is so important when we go into this. Emma, do you have anything to add on that question from the perinatal behavioral health space that you're seeing, again, as most significant shifts in the past year and how you're adapting?
Yeah, absolutely. I would say in the past few years, there's a significant increase in awareness about mental health in the perinatal space and period. I think in the community, there's a lot more of dialogue going on about it. There's been a lot of spotlighting at the national level of maternal health in general, and the state of, this in our country. And so a little bit more funding has been, directed in that direction towards our population. Not a lot. It doesn't really trickle down directly to us on the inpatient side. And I will say, like everyone has said, COVID, right, really, really significantly impacted our population, specifically in the perinatal postpartum period of their lives. Isolation is one of the biggest factors in increasing risk for perinatal mood and anxiety disorders, lack of support and isolation. And that's exactly what COVID did. And so we are seeing an increase in incidence of perinatal mood and anxiety disorders and risk for those things in our population over the last few years. Now it's now up to like 1 in 5 patients will experience this. And so it was very clear at an organizational level at Common Spirit Health nationally that this was on one of our priorities. And so that we took internal resources to make sure that we had a quality bundle in place to do as much as we could to connect our patient with resources before the incidence of perinatal mood and anxiety disorders, the symptoms actually started showing up, that we're actually screening them before they leave our offices prenatally. We're screening them before they leave for their discharge during their delivery stay here in the hospital. And we're making sure that they're connected with those resources that are available to them. But like the others have said on the panel, those resources are limited. And that has been the biggest challenge. We don't have a warm handoff referral system, right, where we can immediately connect them with someone who is trained specifically in the perinatal period, because it is different. Support in this period is different than other behavioral health support needed. And also, a lot of our patients, the majority of our patients are, not either uninsured or covered by Medicaid and Medicare. And so that is challenging when a lot of the providers that are available don't bill through them. And so, cost becomes a big issue for a lot of our communities.
Dr. Franz?
Yeah, agree and echo everything my colleagues have said. Also, just have to call out, be remiss not to just mention HR 1 and the impact that is still likely to have on us in Washington going forward, especially on Medicaid funding and the impact of the removal of the ACA subsidies. So that's kind of looming large out there as I look across the landscape. Would also call out with COVID and the aftermath, just the incredible increase in prevalence of behavioral health conditions. We're seeing across our membership where we used to average about 22% of our members had an identified behavioral health condition. We're now up to 33, 34%. And some of our employer groups, often healthcare employer groups, we're over 40% of BH prevalence. So just a tremendous spike. That's not all bad per se. I think some of the silver linings of COVID was some decreased stigma around behavioral health. So I think more people are seeking behavioral health care, even though I think more people have been under stress from COVID and a variety of other reasons. So we're seeing new incidents of behavioral health conditions. And then I just, as a child psychiatrist, would have to spotlight the emphasis on the youth mental health crisis. We really do have an epidemic coming after a pandemic in regards to the needs of our youth population and what they're struggling with. So that's where my mind goes.
Thank you. And Joan, you have a unique perspective here. You are representing the clinicians too for behavioral health. What are you seeing in this role and opportunities?
Yeah, so I mean, I'll echo a lot of what's already been said. And one of the things I have found most stark over the past years, which Dr. Franz just alluded to, was the reduced stigma of seeking behavioral health treatment. We have found that to be an extremely significant shift since COVID. My job is to talk to lawmakers and policymakers and have them understand what's happening on the ground. Before COVID, we spent a lot of time talking about what are behavioral health services? Why are they important? These are the types of people who have behavioral health conditions. After COVID, we started going in there and they'd be like, oh, I know my child's going through this, my brother's going through that. Like COVID really sort of made a lot of the struggles that people go through seem almost universal, or at least less stigmatizing. And so our members, like Stacey said, we had to hustle with telehealth. We had to figure out how to increase our capacity to meet this greater demand. And it was very challenging, but there was a lot of support at the federal level. There was a lot of federal infusion of funding during COVID that we were able to use to start up new services, to hire more staff, to give bonuses to retain the staff we had that were working so hard during a really, really challenging time. And so now, we are deeply concerned about HR1. We are very concerned that all of the things that certainly there's still gaps in the system, but we have built a lot of things up and we are nervous that we are going to have to start unwinding those as HR1 is implemented. So my member agencies are doing a lot of strategic planning, different budget scenarios. It's a lot of, if this happens, then we're going to do that. And so they're really, I think, working with their leadership teams to figure out how to remain flexible and nimble with so much uncertainty going on right now.
Thank you. Emma, I want to come back to you. You talked a little bit about this, about how like 1 in 5 people are experiencing this. You're alluding to this. How does data quality measurement and outcomes tracking shape behavioral health strategies within your work?
Yeah, that's a great question. Data drives everything that we do. My entire purpose, actually, the function of my role is to collect, abstract, analyze, and interpret data to make sure that we're providing care directed exactly where it's needed in the right time at the right place for every patient. And so, obviously our quality bundle is based both on incidents, but also on, validated tools that we know work and are shown to actually improve uptake into like behavioral health services. So we do use the Edinburgh postnatal depression score. We make sure that every single one of our patients gets screened. And so we track compliance rates is the most important thing for us within our quality bundle. The elements of our bundle are, did the patient get screened? If they are screened as high risk, did they get connected with a social worker prior to discharge? so that they are connected with all the resources they need on this outside. Did the OB get notified and a collaborative plan of care be put in place before the patient is discharged? And did the patient receive, every single patient, regardless if they're high risk or not, receive education about perinatal mood and anxiety disorders, what the symptoms are, what to look out for, and how to get help? And so I actually go in and audit every single time. We don't meet any one of those for every single patient. We started this project a couple of years ago, and our compliance rates initially rolled out around 50%. And I'm really proud to say that as of this month, we're at 90% compliance, which is our goal. There are going to be times where it's not always appropriate or possible operationally to do every single one of those things. But the entire piece is that we were using data all along the way to help inform us with operational changes we needed to make. Gaining extra FTEs for our social worker, having a social work that's dedicated to our birth center rather than a generalist. Like a lot of the decisions that were made and changes that were made operationally and how to use the resources that we are given are entirely driven by data, because that is what's really going to tell us how to make sure that's the feedback we need, right? Are our patients actually getting connected to the resources they need? We would love to have more data on the back end. We just don't have access to all of that, right? So we'd love to know how many of our patients that did get referred out or screened high risk actually got uptake, right? The actual, did they hand off work to community resources? We just don't have a way to gather that data currently, but that's kind of like the next phase of our project.
It's funny you say sometimes that data can help clients. And so, Dr. Franz, do you want to talk a little bit about how the data from the health plan perspective, where there's silos, right, within our healthcare ecosystem? Like you have some of the information, health plans have some information. What, from the health plan perspective, are you seeing as data that are driving your work with your members?
Sure. Yeah. So I think in our preparation, you mentioned there's data, and then there's quality measures, and then there's outcome tracking, and we really use all of those to help us guide what our strategy is going to be. And starting with data, just annually, we're constantly refreshing our data to inform where should our strategic priorities be. For example, where are the gaps in our membership that aren't receiving care or don't have a specific modality? For example, we discovered that dialectical behavioral therapy was a modality that was in scarce supply, especially funded through insurance. The Seattle area has a lot of people providing DBT, right? But very, very few of them accept insurance. So there's this big gap in who can get DBT. So we used that data to then go after a provider that was willing to take insurance and that could broadly offer DBT virtually across Washington State. So that's an example of how looking at data where we have gaps informs our strategy. Then there's quality measures, and this is very insurance heavy here, so pardon me, but we've identified that we really have been underperforming with some specific HEDIS metrics, and some of you may be familiar with these, but they're what we use for our accreditation for NCQA, and this gets looked at by NCQA. And specifically, we've been struggling with follow-up after hospitalization within 7 days, follow-up after higher level substance use disorder within 7 days, and initiation and engagement of treatment for substance use disorder. So we've looked at that, we've seen where we're performing, and now we are, a big part of my day job now is turning that around by working with our provider partners and aligning with them so that we can get our members to follow up in the time they need. It's not just jumping through a HEDIS hoop to get an accreditation. The main reason to do this is because it's better care, but this type of data and measurement really informs us and helps guide us where we should put our resources. And then the third component of this data is outcome tracking. And this is one of the most exciting developments in behavioral health, and we've been a little bit late to the game, understandably. We haven't been able to measure much in behavioral health, or we didn't think we could for quite a while, right? An endocrinologist can look at hemoglobin A1Cs, a cardiologist can look at ejection fractions. What do we have? Well, we now do have some outcome metrics. And I think we've all probably heard of PHQ-9s and GAD-7s, but now we can also look at how are we doing with functional improvement? And yes, how are we doing with decreasing total costs of care? So I think it's been really revolutionary that we now have behavioral health providers actually doing measurement-based care on a daily basis. And from a health plan perspective, that's who we want to contract with, and that's who we're going after proactively to contract with, are those provider organizations that can demonstrate value by providing those outcome metrics that we want to see our members improving with their clinical health.
Thank you. Stacey, you work in this all day and with your operations background. Can you talk a little bit from Sound's perspective on this work with using metrics to inform your work?
You know, it's really interesting. We are the flip side of the Dr. Franz conversation, right? We do the same thing. We are the provider organization who is out there working with, we're the ones who are meeting the HEDIS measures, right? We're the ones who are doing the follow-up after hospitalization. So we do a lot of tracking to those HEDIS metrics, always striving to improve. And again, there's the improvement for the sake of the sort of bureaucracy, but then there's also the improvement. It is the best care, right? So they didn't just make those up. So we work on that level. Because of the size of Sound, we have, and the variety of programs, I mean, we have 700 clinicians, and so we probably have 25 distinct programs. And so the way that we measure client care, we do a lot of measurement-based care, but it tends to be unique to the population or the program. So we do a lot of that. We also have one of the interesting measures that we've been doing. We have certified community behavioral health center grants, they're SAMHSA grants. And they have a particular data set that we have collect. And it's really nice because in the community mental health center space, we don't generally have the financial backing to have data people and collect a lot of extra data. We tend to run pretty slim, but with the funding from these grants, we have been able to, we have a statistically significant sample size, and it's a particular defined data set from the feds. And so we're collecting it on 10% of our people. And it's really interesting because it is across those functional areas of life. And it's been a really great exercise to watch how people involved in various programs are functionally improving over time, right? So we are very interested in being able to continue sort of our expanded use of data that we've been able to achieve using those grants.
But I want to recognize that data is a really powerful tool when used appropriately. And also we need to take responsibility with data and who's behind those numbers and what is the story being told and seen, and making sure people aren't missing or being used, those numbers being used inappropriately. Esther, if I understand correctly, I believe your group works really closely with the Urban Indian Health Institute and the work, but I'm just curious, how is your role working with both the data, and maybe it's qualitative or quantitative, and ensuring that it's really supportive of your population and where your group is trying to go forward? And
yeah, and to be clear, the Urban Indian Health Institute is our public health arm of our organization. So we actually operate it. And it's one of 12 tribal epidemiology centers in the nation, and the only one that has a national scope. So we actually have the status of public health authority, just like the state does and just like the county. So we have been very effective in utilizing data. We've coined the term decolonizing data so that we can tell the full story. I'll give you an example of that. This is specifically important to kind of culturally attuned care, is like, there's this common perception that American Indians, Alaska Natives struggle with substance use disorder, which there is some truth to that. But also our youth have the highest rates of abstinence. And so being able to share data in a way that tells the full story has been important. I'll give you another example. We've been able to track data for innovative projects. So again, going back to the traditional Indian medicine piece, we now have 3 years worth of data and seeing like really significant impact. So for example, if for our folks who tested high risk for suicidal ideation, by receiving traditional Indian medicine services, and of course with other services, we were seeing a 76% reduction in suicidal ideation just by accessing traditional Indian medicine. So I think it's very important that we utilize data in ways that demonstrate promising practices, also model community-defined evidence, right? Because if we get stuck in the evidence-based practice system, then we're obviously going to be stuck with only a target population that often isn't reflective of the communities that we serve. So I think that that's very, very important. I also, if I could go back to the last question just for 1 second, I think it's important for us to call out the challenges with workforce. People leaving the workforce and the challenges with getting people back into those roles. That's also really impactful. So I think that's what I want to share.
Thank you. I think you actually want to bring to Joan. We're talking about the workforce and ensuring that we have adequate workforce and that our workforce is being supported and not getting burned out. Do you want to provide a few words on that point?
Yeah, absolutely. I mean, we're continue to be in the middle of a very significant workforce shortage crisis in behavioral health and healthcare in general. It is a very difficult job with high rates of secondary trauma, burnout, particularly in community behavioral health. We're working in a system that has been inadequately funded for decades, that makes it very difficult for us to compete in the marketplace and offer salaries that our clinicians deserve. And oftentimes what they do is they come into community behavioral health after they get their, MSW or their mental health counselor masters. We give them the supervision they need for their independent license. And then they get their independent license and they go into private practice or they work for a hospital or they go to a plan. And that's we expect that. I mean, we expect there to be some of that trajectory. And I think community behavioral health takes it very seriously that we often serve as the training ground for behavioral health professionals. And then they move on and provide care in other parts of the system. And we want to make sure if they leave community behavioral health that they are well trained, that they've been well supervised, and that they are not so stressed and burned out that they can't continue to provide healthcare services in whatever system they choose to continue their career in. But we are actively working towards solutions to help retain some of that workforce in community behavioral health. There are a lot of clinicians who love working with this population. They love providing community-based services, and they can't afford to stay, whether it's salary or student loans or a number of different dynamics. And so it's not, I mean, again, part of it is that we would like to pay them more. We would like Medicaid reimbursement rates to be higher. But it's not just about more funding, it's also sort of about how services are funded. And I think one of the best things we could do for workforce is to truly move behavioral health to value-based care, which is something the CCBHC model is, attempting to do in Washington and nationally across the state. That if we pay providers and behavioral health agencies the actual cost of services, in sort of a bundled way, so they're not having to count widgets and pay fee for service and provide services just because it's an encounterable or billable. They can actually do whatever needs to be done for the individual who's in that clinic. And it's paid for through this bundled rate, and that allows them to be more flexible with their staff. They can be more innovative with their programs. They can start doing more care coordination. They have funding for data analytics. Behavioral health is woefully behind on quality measurements, and part of it is that inability to track data, and a lot of it is that when the behavioral health system does well, we save other systems money. We reduce ER visits, hospitalizations, interaction with child welfare, and that's really hard to measure. And if you're a clinician working in a very stressful setting and you're not able to see your patients getting better, you're not able to track those outcomes, it can feel demoralizing. So I think there's a number of different strategies that we can do to support those clinicians in this field.
Thank you. I'm hoping I heard my sound was cutting out, so I'm turning my camera off momentarily, hoping you can hear me better. So I apologize for that. I just want to invite this to be an open question, see if others have any commentary to recognizing going off this topic is access to behavioral health care is often limited and for a lot of reasons, provider shortages, cost barriers, and others. What steps are you taking in your organization to improve access or availability, and how do you feel like we can come together to solve this problem? Not sure if others would like to comment on that.
I have a couple thoughts actually. Um, so everything Joan said is correct. All of that is true. And we have actually made some gains in the last few years. There have been some increases to behavioral health Medicaid rates, which we are very grateful for. We have been able to increase some staff salaries, so we are not sort of as far below the private practice bar as we were. There have been a lot of efforts from our educational partners and other private foundations to get people through and into the behavioral health workforce. So we are really starting to see that increase in volume come through as trained as, newly graduated level clinicians, but we're starting to see it. So that's wonderful. I think we continue to look for areas to support at Sound right now. I think we are supervising for licensure about 115 clinicians. That's a lot. It is. We Tetris. Like, how do we get the right person, the right supervisor for the right number of hours? So that is something that we continually work on. We also provide a lot of internships. That's our other contribution to workforce development is we have usually between 80 and 100 interns every year at Sound. So not only are our clinicians trying to provide services, but our longer term clinicians and our leadership are also trying to develop and support the next wave of clinicians, the next generation. So to Joan's point, any of the programs or supports that encourage people to stay in our system instead of getting their license and moving on are very much appreciated, and we utilize them as heavily as we're able to.
Dr.
Yeah, a couple of things. One is, as part of our strategy, we really have taken on a virtual forward approach for a few reasons. One is it's very convenient for a lot of our members to get their services virtually. It is true that some people do not want their services virtually. So I must just make the disclaimer, it's really important that we also offer in-person services, especially when clinically necessary for whatever that presentation is. But in behavioral health, I think we all know now that virtual services can be applied in a very clinically astute way and meet the needs. It's very satisfying for members, patients that do engage in these. And it does really broaden the availability of behavioral health resources to our membership, especially in rural areas where our members are not close to a facility or an outpatient clinic. So that's been a big part of the strategy. And right now, and this is true across the nation, about 50% of all professional behavioral health services are rendered virtually. And that's been static coming off COVID around 2023, that flatlined, and we're still at about 50%. So that's really not changing. And we've partnered with some national BH strategic partners who offer these services at a IOP level, intensive outpatient level, maybe a specialty level, such as for treating OCD, or 100% virtual intensive treatment of eating disorders that's been able to obviate the need to refer people to residential treatment 4 states away. So you don't have to have a child removed from their home, away from their parents, who are really absolutely essential for family-based treatment for eating disorders. So it's been innovative. It's brought increased access. And in addition to that, it's also one of the things I'm more proud of, and this speaks to what Stacey and Joan have mentioned several times now, is we now have an incident to billing policy that allows our members to have their behavioral health services rendered by associates. These are, that's another term for these clinicians who've not yet gotten their licensure, but work in Stacey's organization or the workforce that Joan oversees, largely in the Medicaid line of business. But we as a commercial payer and Medicare Advantage payer say, as long as that clinician is on track with their board to get licensure and has a supervisor within that organization and that you're documenting supervision, you can render services to our members because we're ensuring a level of quality. That's really critical from my perspective, because we don't want these folks that are in perpetuity not pursuing licensure. But it also really broadens the workforce and also diversifies the reimbursement to these historically Medicaid-specific provider organizations that can then be getting some commercial health plan revenue in addition to Medicaid and maybe state general funds. And that really broadens access for our members to a whole nother type of provider.
Thank you. I'm sorry, I'm having some issues with my connection where I think it's hard to hear me, so I'm going to be off camera and hoping that helps. Emma, I believe I saw your hand first, and then we'll go to Esther.
Yeah, I wanted to kind of piggyback after what Dr. Franz was talking about as far as virtual care. So we're actually trialing, not at my side at St. Francis, but at St. Anne Hospital in Des Moines, Burien area. We are trialing a program called Postpartum Wellness and Recovery, and it's actually basically a hand-in-hand virtual remote monitoring program in which a nurse navigator, like a care coordinator, is assigned to any patient that scores high for our EPDS screening there. They also do this for like patients who have hypertension and gestational diabetes, so just general high-risk patients. They trialed it first in hypertension, and they're now rolling it out for perinatal mood and anxiety disorder. But what they do is they pair them with a perinatal nurse navigator who follows up at the 3 and 7 day mark postpartum. And they have all of their materials in, like, I think 6 or 7 different languages currently. Obviously, they use interpretive services for every interaction with patients that don't speak English. And they are able to do remote monitoring for blood pressures, but also for APDS forms, increase in symptoms, concerns. And they have touch points with that nurse navigator every week for the first month, and then every month for up to 6 months. And if any concerns arise or changes need to be provided, then that nurse navigator sets them up with a virtual appointment immediately with the OB and is able to get a plan of care in place, and whether they need adjustment to their medications. We also have a pharmacist and a cardiologist on the team. And so that has been really revolutionary. It is literally, we just rolled it out for PMAD, but for hypertension, it reduced hypertension readmissions by 66% in the first 6 months. Cost savings of up to $150,000, like immediately upon implementing it, pays for itself. So things like that are just, it's using the same resources available to us, but looking at how can we make sure that we're creating that connection that between the inpatient and the outpatient side of things, and meeting patients where they are. I think that's the biggest challenge. And I think that's kind of what Dr. Franz gets to, is meeting patients where they are and diversifying the resources available to them without them needing additional resources to get to that resource, transportation, access, et cetera. So that's been something that we've been able to do on the inpatient side. We're hoping to expand that to all of our sites. St. Francis will be next. It is currently grant funded, which is the challenge. So we're working on operationalizing funding for that. But I imagine that also kind of hand in hand works with a lot of your work, Esther, and that culturally attuned care. That's something we're really trying to put another layer into that program with community health workers. Our nurse navigator does work on the community health team, and so they have a lot of feedback from our communities about what works for them, the type of access they need, the type of care that they want, and that's kind of what this program was born out of.
I'm glad Dr. Franz talked about like the behavioral health aid option, because I know that has really benefited our tribal communities, particularly in rural environments. So I think that helps improve access. I would also say that, our Indigenous Knowledge Informed Systems of Care model, or Indigino, is really designed with that comprehensive care plan, and we've had to build internal capacity. So we've had our largest cohort of MSW practicum students, and they actually fill the role as clinical social workers within the care teams. And then that can lend itself to being able to refer, to ongoing, whether it's mental health therapy, SOD, or whatever it is you need. On the other side, we've also been able to incorporate our primary care practitioners into our intensive outpatient program so that they can get that comprehensive care through the group visits. And so that's been very useful. And we also work to implement on the mental health side something a little bit more along, if you think about like kind of perinatal care and all of the ways that you get physical health support along the way is parity mental health in that same way. So you're doing a lot more prevention work, which is really good. On the inpatient side, having a carve out so that we didn't have to necessarily go through the county system for the assessments and placements, and being able to work with our tribal communities directly helped us reach some of those folks that are otherwise, just kind of weeded out through the system. And so, for example, when we operated our residential treatment program in the past, prior to that carve out, we had a hard time getting above 30% Native in that program. And then after we received the carve out so that we could, remove the middleman and work with the tribes directly, we were at 80% Native in our residential treatment program. So I think it's really important to look at systems and how they can, themselves be a barrier to access. So I echo the sentiments around telehealth. That has been really instrumental in us being able to serve folks from, a variety of different socioeconomic perspectives. And so, so I think that's what I would add.
Thank you. I'm hoping you can hear me. What are some strategies, techniques, and methods to optimize for virtual behavioral health visits? We've been hearing about telemedicine quite a bit, so I'm curious how to optimize this. And then also, I want to add, we're touching on the cultural lens. Is there anything specific or ways to support culturally attuned care in a telemedicine visit that we should be aware of? I'm not sure, Esther, if you've been working on that at all or navigating that, or if that's just uniquely something you're already offering and already in your design that it just is then given over a virtual state or not. But I'm kind of curious for both those questions and others to ask about optimizing behavioral health visits through telehealth and virtual options.
Sure. Well, I mean, I can leave the optimization to the more technical folks here, perhaps. But on the cultural attunement, that was a really interesting question to hear because it's just kind of our way of moving through the world, right? Like, so although you can't offer like medicines, like sometimes we'll offer smudge and things like that, there are ways that you can incorporate prayer, like kind of cultural teachings, like ways to strengthen cultural identity that I think that can still occur through telehealth. I think that, it's interesting. Telehealth was implemented in our organization during COVID, like everybody else or many other folks. And one of the things that we had to do for folks who didn't have access to technology is we created like these kiosks so people could come on site and we could have like a socially distanced visit if they could access our technology on site, and then we could kind of cleanse the space so that could happen. But I think what I would say is that telehealth is actually allowed us to increase the capacity of our providers, right? And it helps us also address the no-show challenges. So for example, we can call somebody who's maybe pending a visit if somebody doesn't show up, and then they can have a visit in real time. And so that really helps with that as well.
I think, let me just chime in here. I think some of our BH strategic partners who are virtual forward or virtually exclusive have some really innovative ways of working with our members. First of all, and I was kind of a late believer in this, but I don't think you always have to have synchronized video. I do think synchronized video is important for a mental status exam or for some nuances of some behavioral health conditions. And I think it's always a great option to have. But we're actually seeing research now that even having a live chat option is another way to communicate between a clinician and a member, or if it's intermittent telephone call or some virtual worksheets, if you will, to work on in between sessions. And that's a great thing about the virtual platform, is that it allows the back and forth of data. So, for example, you can much more easily collect clinical outcomes data using a virtual platform because it's integrated, and you're doing your phone call, you're doing your video visit, you get your PHQ-9 before you start, you fill it out the next week. The clinician gets real-time information. I think in many ways, this can connect the patient much more to the clinician and really leveraging what the virtual platforms offer than, say, the brick and mortar environment that I do my Friday afternoon work on. It's much more much more difficult to do measurement-based care. No-show rates can be higher, these kind of things. So I think the virtual modality lends itself to really meeting the patient where they are in a variety of ways and using different modalities, whether it's voice, text, chat, synchronized video. And these are just all great options for our members.
Thank you. My next question is, how are we working to ensure that behavioral health services are culturally responsive, community-driven, and centered on lived experiences? Stacey, in your intro, you were talking about the peer perspective and when you're out in the community and a peer showing up. Could you elaborate on what Sound Behavioral Health may be doing to support culturally responsive care?
Sure. Certified peer support specialists are an important part of our workforce. We have them across our organization. So we have, for example, for our child and family teams, we have a very particular program that serves kids with very high levels of need, kids and families. And so in that program, we have two kinds of peers. We have a parent partner who goes out and supports the parents, and we also have youth peers who work directly with the kids. So that's one example. We use peers in crisis. Peers are folks who have gone through a series of trainings, and their qualification is evolving right now. As of January 1, 2027, it will be a little bit different, but right now they have gone through a training series with DBHR, and they get a certificate, and they learn these competencies, and then they join our workforce in a variety of ways. And really, they are the embodiment of hope and recovery. And that's what they bring, and they bring an entirely different lens. They are able to partner with people and support that hope and empower people to make choices that support their own recovery in ways that they need to proceed, right? So we use peers throughout our organization. We probably have 50 maybe, and they are part of the care team. So someone will have a clinician, they might have a nurse care coordinator, they might be assigned to a peer, they might have a doc. We recently added OT. So we take all of that, and the peer really helps the client drive their own choices in recovery.
Within your work, how you're supporting culturally responsive care, community-driven, and centered with lived experience?
I'm sorry, was that for me?
Open to anyone who would like to add it. Yes.
Okay, sorry, you cut out at the beginning. So, but I will definitely answer. So, we have a commitment. I said, like, we have 31 different training programs within our organization, dedicated to training the next Native and Native serving workforce, particularly related to behavioral health. I'm really proud to say that 90% of our practitioners, both on the SUD side and the mental health side, are Native, and that is really helpful. So targeted recruitment, and then for the folks who are non-Native to become more culturally attuned, we have weekly trainings that really support the development of those skills that help meet our relatives that we serve where they are. So super proud of that work. And it takes investment, to be able to not have clinicians on the floor to do that work, but to really invest in their training. And so I think that has been an incredible value to our organization around cultural attunement.
So I just want to throw out We have worked incredibly hard to diversify our workforce. So a lot of the grant-funded programs and the push around expanding educational opportunities, particularly for BIPOC folks, has once again created a great downstream effect. We are now reaping the benefits of those programs, and the diversity of our staff has increased in a really amazingly great way. We now actually, our staff demographics matches the demographics pretty closely of the communities we serve. And that is very different for the community behavioral health system. So we are very grateful for all of the upstream work that gets done, helping a wide variety of folks enter the behavioral health field. There's been a lot of effort over the last, I would say, 5 years probably, to encourage people from all kinds of communities to enter this space. And there's been an acceleration of alternative methods to bring people into this field. You no longer have to go get a master's degree. You can start as a peer, and then you can go become an apprentice to be an SUD, and you don't have to go through that formal educational system. So all of those efforts around workforce development have also really helped us provide more culturally attuned care by diversifying our workforce.
Thank you. I'm hoping you can again still hear me. Emma, I have a question for you on this. Is we've heard about kind of working on your building your workforce. We've talked about culturally responsive care. I'm a little interested with your role is how do you address biases with your current staff? So in ensuring that people are getting appropriate care, but you have staff, you have a need of a unique population that may not come through your door every day. I'm just curious, how are you addressing any biases that might come up within your current workforce who are not behavioral health specialists? This is rather a subpopulation that they work with, and just any comments on that?
That's a great question, Emily. I wish I had a great answer. So we have a few techniques that we are working for, but that is definitely one of our goals ongoing. We do implicit bias training with all of our staff immediately upon onboarding and ongoing. So our goal is at least once a year. We're trying to do them more often than that. We also do, we call them M&Ms, like case review, essentially, but it's kind of a de-identified generalized case review of incidents in which maybe care wasn't optimal, or there were incidences of bias that played into care. And we open those to the entire department, including all of our, like all of the disciplines, right? Not just our nurses. And that has been really helpful in just opening dialogue and kind of drawing people's attention inward to reflecting upon the way that their, implicit bias that they're completely unaware of has played out in the care that they provide to our patients. And then I think the key for us is because our quality bundle is measurable, it is a yes or no, did it happen, right? It's really hard for us to know how these things are happening. We don't have qualitative data about it. We just know that, like, yes, our patient was screened. Yes, they were educated on this. Yes, it was provided in their language that they speak. But we don't really know what the reception of that was like with that patient, and the uptake and the usefulness to that patient was. And so that's something we're still really trying to work through as far as like, how do we gain feedback? And some of that is, I don't personally do this, but our operations leaders, our manager and our director obviously do patient rounding every day, every week. And so they check in with our patients and make sure they're getting what they need, and escalate things, address these things in real time. Giving some, just-in-time teaching and coaching to our staff has been really valuable. But I do think that there's still a lot of work to be done. And so I'm partnering with our social worker, specifically for our population that is struggling with substance use disorder. And we're looking at anytime a patient is screened for substance use disorder, meaning a toxicology is run, et cetera. Why was that? What triggered that? What we're making sure that it's actually per our policy, that there were risk factors present, that it wasn't biased, that it played into that screening. Because as we all know, screening is a tool, and universal screening is not ideal for our patient population. It doesn't actually get us better outcomes for them. And so we have to be judicious and aware of that. A lot of the things that we provide in the inpatient setting can affect toxicology reports. And so timing and methodology and all of these things matter, right? The details matter. And so I'm partnering with our social worker. She's helping flag on the back end when I'm not seeing them. I'm trying to pull reports for those labs that are run. and kind of look into each of these cases and make sure that we're providing appropriate care for every patient every time. And so we're still working through a process of what that looks like for follow-up with the staff members when maybe we didn't quite meet the mark. But that is ongoing work.
Thank you for that. I want to ask Joan a question because we've been talking about direct patient care for a little bit. I have a question about, and there's a lot of changes happening, right, on the policy front. There's some questions that were put in the chat about this. What policy changes at state or federal level would have the greatest impact on strengthening behavioral health in Washington state at this time? And how can we build resiliency around this as we're navigating some challenges from other policies occurring?
Yeah, so there's definitely a lot going on. I think one of the greatest impacts we could have at the policy level is to have more targeted investments in prevention, early intervention, and outpatient care. Oftentimes, and particularly in state policy, our lawmakers respond to expensive lawsuits. And obviously, that is totally appropriate. But those lawsuits usually relate to deeper ends of the system. So we see a lot of money going to the crisis response system, to the state hospitals. And we will always have some individuals who may need a state hospital at some point in their lives. We must have a functioning crisis response system for people who are in a behavioral health crisis. But we can't keep funding those systems at the expense of upstream interventions, which is a lot of what I see happening. We have so much opportunity to lower costs and, more importantly, to prevent trauma and provide earlier supports to people and families who need them. But we make a lot of investments in beds, in crisis, and hospitals. And I do think that that is sometimes at the expense of outpatient care, which we have a lot of opportunities to help people before they need to call 988, before they need that hospitalization. And so that's something that I would love to see happen more broadly.
Emma, see that you have a
I
comment?
couldn't agree more, Joan. And I think specifically in our population, our patient population, that means paid parental leave for all, both the birthing parent and the non-birthing parent. Free postpartum case managers and nurse home visits for every new family to support them in that transition to home, and postpartum doula support for all families. And those are the things that will literally prevent almost all incidences of perinatal mood and anxiety disorder. If we create a space of wellness for our new families, we are not going to have the incidents that we see currently. Our system would be able to handle the incidents that occurs. But like you said, you need investment at the federal level, really, more than anything.
Hey, Emma, I think a question came through the chat when you were speaking earlier that I missed. Could you go back and talk a little bit about how you're incorporating assessing and addressing social determinants of health or social drivers of health through your screening?
Yeah, absolutely. So the EPDS form doesn't directly address social determinants of health. There's like a few questions that address it, but our social workers do a full assessment. So any patient that's at high risk for perinatal mood and anxiety disorder, do a full assessment of social determinants of health and provide resources and connect them. That's specifically inpatient at St. Francis currently. The postpartum wellness and recovery program that I mentioned earlier that exists at St. Anne, they do a full SDOH assessment in conjunction. So both the nurse navigator, the inpatient RN who initiated the referral to the POWER program, and the case manager or the social worker work together on social determinants of health. And they are able to connect them to community outpatient resources in a much more warm handoff way. And that's our end goal, is to be able to do a full assessment for every patient that needs it. And I mean, I'd love to see that for every single patient every time. But right now, it's for patients that are the highest risk.
Thank you. We're getting close on time, so we're going to wrap up with one last question, and I'll ask each of the speakers. If participants take away one action or mindset from today's conversation, what would you hope it to be? And I'll start with Stacey.
Oh, one is hard. But one thing that got triggered for me today was putting together the comments about backing up care towards prevention and our youth. And I think that we must focus on figuring out how to support our youth to prevent them from getting deeper and deeper into the system, and so that they can grow into happy, healthy adults. I think we've got to focus on our kids.
So Esther.
I think it was, yeah, you kind of broke up. Is that me again?
Yes, I know. I'm so
Okay.
sorry.
That's
Thank
okay. That's
you.
okay. Yeah, when I hear like S, I think that's me. So, I think that, just like hopefully what we're taking away is just like listening to community voice, around and what it truly means to meet people where they are, and to really value community knowledge in, treatment modalities. And then overall, the full continuum. It has to be prevention, early intervention, treatment, all the way through aftercare. Because without funding the full continuum, we're going to have a breakdown somewhere.
Thank you. We'll have Dr. Franz.
Yeah, I would just say this is all so tremendously complex. It takes all of our voices to really collaborate to try to figure this out. And I know a lot of us have been doing this for a long time, and we just got to keep at it. And we've got to get the community voice as involved in as possible, the patient voice, that lived experience, the providers, the payers, the regulators. I mean, we are all pieces of the puzzle, and it's these kind of collaboratives, if you will, the Washington Health Alliance, the BRIE Collaborative, this presentation. I really think this is where it's at, because we might spark an idea. We might also build some trust, because not all those systems always play nicely together in the sand, and we need to, because I think we all care about the health and the outcomes of the people we serve. So I think it's ongoing collaboration.
Thank you. Emma?
I couldn't agree more. And I do think, implementing large scale programs and systems change is thankless, tireless work. But if not us, then who? And if not now, when? Like we are the ones in the places that can do this work. And so even though, systems that exist and powers that be may not make it easy to do the work right now, it's still worth doing. Because we're creating not just, like Esther said, we're not just looking at one side of the spectrum, right? We're not just trying to fix problems that already exist. We're looking at prevention. We're looking at creating wellness for entire lineages of families. There's a lot of data out there that shows that, trauma is generational. It lives in our mitochondria, in our cells, in our bodies. And so if we look at, preventing, stopping trauma currently, helping treat those that have been traumatized and need behavioral health services, but also preventing that trauma from existing in a mother who then passes it down to her child, who then passes it down to her grandchildren. We're looking at generational healing here. And I think that that is something that we're not going to see in our lifetimes and can be very difficult to conceptualize and feel rewarded by, but we just have to keep showing up, because it's going to be worth it, for our children and our children's children someday.
Thank you, Emma. And Joan?
Yeah, I mean, I agree with what all of my colleagues have said. I mean, I guess I hope the takeaway is that, community matters. If you are one of the helpers, keep being one of the helpers. We're fighting the good fight and doing the best we can for the people we serve. And I guess I'll leave everyone with just like a little nugget of hope as I sit in my little policy office, and we're coming to the end of a very tough state legislative session where lawmakers are trying to balance the state budget. And both the House and the Senate released their proposed budgets that made very minor cuts to behavioral health. There are some programs that are getting reductions in funding, but it is not an across the board cut to all behavioral health services and systems. And this is very, very different than what happened during the Great Recession, where the legislature balanced the cutting direct service delivery for behavioral health. And not doing that this time. And I think the proposed budgets that have been released, at least to me, are very evident that we have policymakers in our state that are trying really, really hard to keep our systems intact despite all of the uncertainty coming out with HR1 and the federal level. They are making tough choices, and I think they recognize how important these services are to our communities. So I think that is good news.
That is great news, and thank you for sharing that with us. We are at time, so I want to thank everybody for joining us today, and thank you to our speakers for sharing your time, knowledge, and expertise with us. We are so grateful to have this conversation and keep uplifting this work in the state. So thank you, everybody, so much. We hope to see you in the future at our future events.
Thank you.